Good afternoon, everybody. This is Dr. Mark Rudolph, Sound's Chief Experience Officer. Thanks very much for joining us on this week's COVID-19 clinical webinar. As always, we will have Q&A at the end of the presentation, so please feel free to submit your questions via the webinar control panel at any point during the presentation. We are recording the webinar and we'll send it around via email to all invitees with a link to the recording, as well as links to resources that are mentioned during the presentation. And at this time, I'd like to turn it over to Sound's Chief Medical Officer for Hospital Medicine, Dr. Gregory Johnson. Greg?
Thanks, Mark. I appreciate that. As we always begin these webinars, we first want to state our gratitude to all the fantastic work that we continue to see, hear, and read about with respect to our collective programs in critical care, emergency medicine, hospital medicine. What you all are doing for the communities that we serve is exceptional, and you just need to hear thank you regularly. So this is one of the venues that we provide that. As always, we have our typical agenda for the webinar. Most of you are pretty familiar with this now, but we'll have the Sound update, a discussion of influenza and COVID-19, our testing updates, and then further information on clinical initiatives related to COVID. As Mark mentioned, we will also have our question and answers. Please make sure that you're entering any questions that you have into the chat box so that way we can aggregate that and answer. So I'll move directly into the Sound update. As we have highlighted regularly on this call, what the gold line are the active patients that are either suspected or confirmed COVID-19 patients across our critical care and hospital medicine programs. What's in the blue line are the new admissions to give a sense of the patients that are coming in overnight. As you can see, this graphic indicates going back to tracking of patients back to March, when we first were able to collect this information. And as you can see, we are on a decline in terms of number of patients that are coming in, and it looks like we've plateaued with respect to new patients. In looking at the next slide, you'll see that we are still obviously aware of patients, of sites that are increasing in number of patients. For those who check this regularly in Sound Metrics, you can look at your individual site or sites that may be in your respective regions. In this week's update, we have a significant concentration within the Cincinnati markets with the Mercy hospitals and Fairfield and West. We're also seeing upticks in Oklahoma City. We continue to see high volumes in California, Texas, and South Florida, but we're continuing to monitor all of this on a pretty consistent basis to make sure that we're adequately supporting those programs and have a good sense of where potential hotspots are arising across the country. The last slide we haven't shared on a consistent basis because there haven't been a lot of changes with respect to the data. But again, in looking at suspected and confirmed cases, as well as the overall mortality, we're not seeing significant differences either. We just wanted to make sure that this was shared again and note the consistency with respect to mortality and increased age, particularly those patients who are over 65. The number of confirmed cases, again, in the middle, has gone up with respect to the 40 to 54 range, which is very consistent with what we've seen in other publicly reported data sets. So now we'll switch over into a subject that I think lots of people have expressed concerns over, and that's with respect to what we typically see nearing this time of year with influenza and COVID-19. And just so everybody knows, the next slide indicates that this is getting a lot of play with, especially with respect to scientific, journals. A lot in Science and JAMA, and we'll get into what a lot of these particular articles state. One of the things obviously we have to remember is that with this being a novel coronavirus, this is a novel experience with respect to the overlap. And so the information is somewhat speculative, and there is still a lot to be learned with respect to what is going to come of this. Next slide. So just in terms of some facts, first off, when discussing pandemics, we have to remind ourselves that many of us were practicing during the global pandemic with respect to H1N1. And to put things in perspective, you can see the data that's there: 61 million cases, 274,000 hospitalizations, and 12,500 deaths isolated to the United States. The H1N1 virus is now one of the primary influenza A strains that is noted in the pandemic, and it has since 2010 been the virus that's also been introduced into the vaccine. And I think that's pretty important as we get into some of the factors that are being considered with respect to the overlap of COVID-19 and influenza viruses in general. Next slide. So challenging to read in terms of this slide, and we'll provide some highlights with respect to what is to be garnered from this particular slide, but there are concerns about making sure that there are defined areas of similarities and as well as differences between SARS-CoV-2 and seasonal influenza viruses. So if you go to the next slide, first in terms of similarities, there are a couple. There are both are typically droplet, although SARS-CoV-2, there's some concern about now whether or not there's airborne transmission. The risk factors are quite similar in terms of chronic diseases, in terms of advanced age, and with respect to the common clinical manifestations, which is going to be a huge confounding factor as all of us are trying to evaluate these patients. Fevers, chills, headache, myalgia, all of those things are pretty consistent. In terms of the differences, next slide, we want to make sure to highlight some very specific areas that were called out in a number of the articles that I referred to and will be available after the webinar. The first of which is that typically in the seasonal influenza, the patients are infectious immediately after symptom onset, and they are also infectious over a period of time, whereas in SARS-CoV-2, there is at least what has been documented to date is that the patients who are infected are most infectious early on. The incubation periods are obviously quite different, much shorter with respect to seasonal influenza as compared to SARS-CoV-2. Pediatric disease for our pediatric hospitalists, for emergency medicine physicians, there is definitely different disease, much more common in terms of pediatric disease for seasonal influenza versus COVID-19, although the more serious diseases like the multisystem inflammatory syndrome have been documented in SARS-CoV-2. The other piece that people are frequently pointing out is the case fatality rate. We know that lots of patients die with respect to influenza, but it is a higher rate in COVID-19. Part of the reason we go into the clinical characteristics is to understand that there are implications in terms of knowing what you're treating. First off, some of the basics. We know that supportive care does overlap, but we know that also drug treatment doesn't. I think from the perspective of an acute care practice, things are pretty meaningful with the second and third bullet points. Treating influenza patients as if they have COVID has been documented as a concern. We know that remdesivir is useful in moderate to severe COVID, but it's in short supply. And so making an assumption of a potential influenza patient that has COVID has resource allocation concerns, as well as the concern of whether or not the patient's receiving the appropriate treatment. Secondarily, we know, and I know that Sergio is going to bring up later on about dexamethasone being found to reduce length of stay, but systemic corticosteroids are recommended against being used in influenza. And so there has to be some additional level of thought in terms of patients being treated for the right condition at the right time. And then finally, we know that we don't typically quarantine our influenza patients, but proper disease identification absolutely makes sure that we're getting patients the appropriate quarantine, making sure that their families are being appropriately informed, making sure that we're making the right recommendations in terms of once these patients are being discharged. So a lot of different considerations that need to be taken or made when considering influenza versus COVID-19. Next slide, please. Now, in terms of just dealing with the two diseases occurring simultaneously, this is a shift in the discussion, but really getting into what are some of the influencing factors that are going on with the fact that we are dealing with a COVID-19 pandemic and anticipating flu season. Well, one of the first things that's gone on with respect to this overlap in terms of influenza and COVID-19 is whether transmission is going to occur in the same way. For other countries in the Southern Hemisphere that have already had their influenza season or their historic influenza season documented, you see on the right, the cases have gone down considerably. And yeah, when you see that number 6 reported for South Africa, lots of people have different concerns. And certainly what came out of this article was, well, maybe testing wasn't done because everybody was so focused on COVID. But the general consensus was that the social distancing efforts, masking, and all non-pharmaceutical interventions had a meaningful impact in terms of reducing the overall transmission. And so the potential concern of influenza overburdening the healthcare system during the COVID-19 pandemic didn't seem to pan out for these particular countries. Next slide. Other influencing factors that will affect how this country in particular addresses both COVID-19 and influenza are the vaccination rates. For perspective, we know that influenza was only used about 45% of the time, despite the fact that generally all patients, and certainly those patients who are higher risk, are asked to receive vaccines. Lots of outlets, so please go back. Lots of different outlets are highlighting the fact that we want to make sure that appropriate people are being vaccinated in order to mitigate concerns about overutilization of emergency departments, increased levels of hospitalization, and obviously the mortality that's related to influenza. And that we want to make sure that routine vaccines are underscored. One of the pieces, though, that was highlighted and wanted to make sure that was addressed were the fact that for patients who are under investigation or any confirmed cases of COVID-19, the CDC recommends that vaccination should be deferred until the patient's criteria has been met to discontinue isolation. This is pulled directly from the CDC recommendations and other information that was pulled from MMWRs, and certainly something that needs to be considered in terms of our individual response to COVID-19 and our response in consideration of patients who potentially have influenza. The big concern, obviously, for most people is regarding co-infection. And I sigh in pulling this together because obviously this is a tremendous concern and something that people want to pay attention to. But the simple fact of the matter is that there is very limited data with respect to co-infection at all, but co-infection in particular with influenza related to SARS-CoV-2. And the simple fact of the matter is, again, novel coronavirus, we don't have a lot of data on this. What you see here on the right is the one report that we do have done fairly early in March in this country that identified patients who were either SARS-CoV-2 positive or negative. You can see at the top the negatives are to the left and the positives are to the right. And the only indication of a patient that was co-infected with influenza A was the one patient documented there. There are other studies that indicate a potential co-infection rate of anywhere between 4 and 20%. The 20% seems to be associated with any respiratory virus and not specifically influenza. The only other piece regarding co-infection that I could identify was that was from China, and very specifically that co-infection was associated with longer hospital stays, but no comments on mortality, no comments on any additional treatment regimens. So it's something that we'll keep an eye on, but it's certainly, there's limited information to date. The last piece that goes, that's an influencing factor with respect to what's we anticipate seeing with with COVID-19 and influenza is that it's just further highlighting existing disparities that we have in healthcare. We know that there are disparities already with respect to the infection rate and mortality associated with SARS-CoV-2 and influenzas, seasonal influenzas, although it's different underrepresented minority groups that tend to have different infection rates and mortality for each of them. But one of the key findings that at least was pulled from a couple of articles was specifically that influenza rates are significantly lower in non-white communities than they are in white communities. And I think it's a critical piece of evaluating and encouraging patients to make sure that they're getting their appropriate vaccination schedules in order to help mitigate the potential cost of disease, not only for communities, for the communities we serve, but obviously for specific patient populations. For anybody who is looking for additional information on influenza and COVID, these references, these are articles that were referenced in this particular section, but they will also be available once these slides are emailed out and made available on the Knowledge Center after the webinar. I'll now transition over to Dr. Ruck to give us a testing update.
Thanks, Greg, and welcome everyone once again. So talking a little bit about testing, I think that there's been some pretty exciting new developments. Before we dive into that, I just want to again highlight the availability of PPE that Sound has. I know some of our hospital partners are challenged with PPE availability, and we continue to have a supply of KN95 masks available for distribution. You can request those through the link on the Knowledge Center. And as always, any N95 mask is only as good as its fit. So I would encourage you to get fit tested. And if you've gained weight, lost weight, grown facial hair, shaved facial hair, you need to do it again. Really important component of being safe during clinical work. We mentioned this previously on the webinars, but these mask types that have exhalation valves really are not offering a lot of protection for patients or others. And if you're going to wear a mask like the 3M mask on the left side of the screen, you definitely need to wear a surgical mask over it if you're performing clinical work. So testing, there's been some decrement in the percent positive. The blue tracing on this infographic is the percent of all tests positive in a 7-day moving average. And data from other parts of the world suggests that if you have a reasonable testing penetration and you have a percent positive trend line that moves below 5%, you really increase the safety with which you can reopen. And there's pretty broad disparity between different geographies in the US. This data is from the Johns Hopkins testing project, and I would encourage you to go on their website and check out data for the state or municipality where you are. You can also see that there's some decline in the number of tests being performed in the US. We're trending just a little below 800,000 tests per day. And it is good to see, though, the decline in that 7-day moving average of positivity. So broadly, there are 2 test types out there. And, stepping back from this even a little further, if we had a wish list and wanted to develop kind of the ideal COVID-19 test, what characteristics would that test have? Well, it would be scalable, i.e. no real supply chain bottlenecks. It would have a rapid turnaround time. It would be safe for providers to do, which is a substantial drawback of the current NP swabs, which require a lot of PPE and have the tendency to induce coughing or sneezing. It would be low cost, and it would have good test characteristics. Now, I don't think we have any tests available that check all those boxes, but we are going to talk a little bit today about a test that certainly checks many of them and has some promise, although further research is required. And this test we're going to talk about falls into the left side of this table. It's a viral test that is a permutation of the commonly available PCR test. And as we've discussed before, on the right side, there's serology testing, and really all authorities still say interpret point-of-care serology testing, point-of-care antibody testing with extreme caution, because the validity of the data you're getting is questionable. If you're getting a ELISA serology test done in a CLIA lab, that certainly has credence, but probably requires collaboration with infectious disease. So just by way of review, really the challenge from an infection control standpoint and what led to a lot of the controversy about masks is that this novel coronavirus, well, it's novel and it's really a fair amount different than MERS or the original SARS. And one of the key differences is that people have very high viral loads during pre-symptomatic periods, and there's a fairly high fraction of asymptomatic people. And those are 2 things that are really markedly different than prior coronavirus pandemics, and are one of the things that complicate, contact tracing and infection control. So, the other thing that's really worth highlighting with antibody tests is that, if you think about how the immune system functions and how viral immunity works, antibodies are really only part of your body's ability to ward off infection. And there's certainly some emerging evidence on the importance of T cells. And this may explain why some people have such mild infection. And it may also play a role in why infection becomes more severe as people get older, because there's really compelling data in other infection models to suggest that T cell mediated immune function declines pretty markedly with age. And I think this is an area where we're going to see a lot of research in the coming months. So home testing is definitely a thing. This is a screenshot I pulled from a website company called Everlywell. You notice they say FDA authorized on their test kit. They're not allowed to say FDA approved because these are emergency use exemption tests. They'll have you video chat with the licensed provider, and you can, for $109, you can have a test mailed to your home. This is active really nationwide at this point. It's not clear to me how reporting's working for this testing, and there isn't always great information on the vendor that's providing the test. And these are self-collected nasal swabs, which, there's enough problems with healthcare professional collected swabs in terms of sample quality. Those issues are only magnified through self-collection. So antigen testing we talked about previously, and I don't think this is really mature in a way that's super useful. Definitely checks the box of having potential for home testing. And, the technology here is similar to rapid strep. These are specific but lack sensitivity. Some of the kits out there have showed cross-reactivity with seasonal coronaviruses that cause the common cold. They are nice in that they give a rapid yes/no, but I don't think today antigen testing is the answer to our problems from a testing standpoint. There is, however, a new test out there that I think we're going to see a lot more on in the coming weeks, and that's a product that was, or not really a product, it's a protocol that was put out by Yale in collaboration with others, and it's called SalivaDirect. And this was approved on the 15th of August through an emergency use authorization by the FDA. And its approval is a little bit unique in that this isn't a test kit that was approved. This is a protocol which is open source and has very low cost. It's much less complex than the common nasopharyngeal swab for a number of reasons that we'll go over. It does still require a CLIA certified laboratory. It's not a wave test. So how does this test work? You get a saliva sample. So this is liquid saliva that pools in your mouth, not appropriate for hospitalized patients that have, that may have samples that are contaminated with mucus or blood. You mix this liquid saliva sample, and this saliva sample can be collected in any sterile container. There are no special preservatives required. You combine that with the protease K, you heat it up a little bit, and then you run it through a PCR machine. And it doesn't have to be, a special cartridge and a special PCR machine. This has been evaluated with hardware from multiple vendors. And the nice things about this test are that, there's no nasopharyngeal swab required. So you don't have a huge burden of PPE required to administer testing. Patients can collect their own samples in any sterile container. And one of the big differences here is that there isn't an RNA extraction step. They validated this process and compared it to PCR and omitted the RNA extraction, which adds a lot of complexity and requires specialized reagents. Now, there's a variety of different combinations of widely available and low-cost reagents that this has been tested with. Now, next steps, where are we going from here? There's a lot of ongoing research with SalivaDirect. I'm sure many of you have seen in the lay press that the NBA for their bubble is utilizing SalivaDirect along with, they're pairing it with nasopharyngeal swabbing. And there really isn't compelling data on asymptomatic and pre-symptomatic patients. I think that's really what we're looking most forward to is data from the cohort of 328 NBA players. There haven't been any positives yet, but when and if there are, we'll get some actionable information from that. Pooled testing could further amplify the scalability of saliva testing. There are some steps that could be automated in a better way. And there's preliminary data on the test characteristics, but the sample size and power of that data is low. So we've had some issues with people rushing to publication with things related to COVID-19. Hopefully that's not the case here with SalivaDirect, and certainly we'll keep an eye on this. So with that, all that being said about testing, we'll move on to clinical updates and transition to Dr. Sergio Zanotti.
Thank you, Nate. We're going to talk about a couple of interventions and some new studies that came out over the last week. Next slide, please. I want to talk specifically about a new clinical trial in remdesivir, and also talk a little bit about vitamin C and thiamine, which I think have been very commonly utilized in patients, especially in the ICUs with COVID-19, but also with patients with septic shock for other reasons. So this is the NIH guidance as of now for the use of remdesivir, and we talked about this when we talked about our top 5. Clearly, there still is an emergency use authorization in place for remdesivir based on one large randomized trial that was conducted in the United States. Remdesivir was shown to decrease time to recovery by 4 days from a mean of 15 to 11 days in those patients who had severe COVID, which is defined as saturations below 94% and the requirement of oxygen. So based on that, in those patients who are hospitalized with oxygen, and those patients who are hospitalized and on mechanical ventilation or ECMO, the NIH recommends the use of remdesivir. Next slide. And this is the study that actually led to this recommendation, which it was a large randomized study with over 1,000 patients. And again, I think it's important to note that what they found was a improvement in the time to recovery from 15 days to 11 days, but there was really no demonstrated improvement in mortality or in other significant clinical outcomes. So I think that with that in mind, there are other studies that have been ongoing with remdesivir, like Greg mentioned earlier. Remdesivir obviously is in high demand. It's not always available, but trying to understand what's the real efficacy and which are the patients who benefit and how they benefit, if they benefit, I think is still something that is very much in everybody's mind. And the trial I'm going to share now was published this week. Next slide, please. And it's a study that was sponsored by the manufacturer of remdesivir. And what they looked at was in patients that have moderate COVID-19 which is defined as hospitalized patients who have infiltrates on X-ray, so have a diagnosis of pneumonia, but are able to keep their saturations on enrollment above 94% without the use of supplemental oxygen. So these are patients who have pneumonia, but have not yet been placed or requiring oxygen, high oxygen, or mechanical ventilation. Now, a lot of these patients, once they did get enrolled, 15% of them actually got placed on or required oxygen later on, but at the time of enrollment, they had what they would fall in the definition of moderate COVID-19. So this was a randomized study. It was not a placebo-controlled because they didn't have enough vials for the placebo. That is the argument that has been proposed by the authors. And what they did is they randomized a little bit over almost 600 patients on a 1-to-1-to-1 ratio to 1 of 3 groups. The first group got 10 days of remdesivir at doses as similar to what we explained before, which is 200 milligrams IV on day 1, and then 100 milligrams on the subsequent days. The second group was randomized to 5 days of remdesivir. They got 200 milligrams IV on day 1, and then 100 milligrams on days 2 to 5. And then the third group was the control group, in which they were just, treated with a standard of care, but did not receive remdesivir. And you can see how they kind of broke this down, and anybody who got 1 dose was considered part of the trial. It's very interesting that in the 10-day remdesivir group, the average number of doses was 6. So a significant proportion of patients did not complete the 10 days of treatment. And in terms of outcomes, the primary outcome was clinical status on day 11, measured on a 7-point ordinal scale. And the scale goes from 1 being death to 7 being discharge. And we'll look at the scale in the next slide. But basically, this is something that's been utilized in a lot of these COVID trials and might have problems by itself. And then they had some secondary outcomes that included mortality, time to recovery, need for mechanical ventilation, et cetera, et cetera. The results of the trial are quite interesting. They were able to show that there was a significant improvement or decrease compared to standard of care in the 5-day group, the patients who got 5 days of remdesivir. And although this was statistically significant, the clinical significance of this was questioned even by the manuscript. So it's unclear how clinically relevant it was, but there was a difference. Now, they didn't find any difference between the 10-day group and the standard of care. So it was only positive for day 5, for the 5-day course. And then when they followed up on the same pattern, they found that by day 14 and by day 28, those patients who got remdesivir had a tendency to have a bigger improvement in their ordinal scale. And here you can see the scale actually, which goes from death being the lowest all the way to discharge, which is 7. And you can see that there's different categories. So it goes from death, hospitalized requiring mechanical ventilation, hospitalized requiring non-invasive ventilation, hospitalized requiring low flow supplemental oxygen, hospitalized not requiring supplemental oxygen, requiring ongoing medical care, which in theory would be the great majority of the patients when they got enrolled, hospitalized not requiring supplemental oxygen or ongoing medical care, and then finally discharge. So what they were trying to show was that there was a significant difference in the number of patients who had better outcomes based on this ordinal scale. Now, this obviously is a study that doesn't answer all the questions. There's still a lot of questions regarding remdesivir in terms of what's the impact of dexamethasone. We talked about that before. These studies were done before dexamethasone, the recovery trial, was published. It's still unclear why we're unable to reproduce a lot of the findings with 10 days versus 5 days. Was that just a design issue? We had another trial that showed that 5 days was similar to 10 days in a similar population, yet the trial that showed the benefit on patients with oxygen and mechanical ventilation was a 10-day course. So still trying to identify what the real role of remdesivir is. I still think that there are more trials on the way. I think that we still will continue to use remdesivir within the scope of the emergency use authorization. But I do believe also that as we get more studies, the precise indication for remdesivir might change. And I think that the real impact it has on these patients, is still to be determined. The next topic is vitamin C, and this is something that I think a lot of people are utilizing. It started, as you'll see, a couple years ago in patients with septic shock. This is one of those therapies that has very, very strong proponents and enthusiasts that I think clearly are out of proportion with the available evidence. When this started, this is from July 17th, the NIH recommended that vitamin C, or could not make a recommendation on vitamin C for critically ill patients and for non-critically ill patients with COVID because there was just not enough evidence. And they have a rationale there of why some people think it might be utilized, but they basically said there's insufficient data for us to recommend one way or the other. However, next slide, you might have seen plenty of stories in the press, in different blogs about great success stories with vitamin C. It's been on stories in CNN and Fox News also. I mean, you'll hear about some of these protocols, and really a lot of attention being given to vitamin C and thiamine as potential therapies that can really make a big difference in these very sick patients. And I know of a lot of our hospitals that actually, under the argument that there might be some evidence that it works and it's not harmful, have really consistently been giving patients in the ICU vitamin C and thiamine with diagnosis of COVID-19, but also sepsis. So where does this all come from? Next slide, please. We've all heard, I mean, for years about the potential benefits of vitamin C in infections. I mean, you can buy vitamin C supplements in the pharmacy, and a lot of people take them during influenza in the winter season or when they travel. But the reality is that a lot of the gained or more recent interest came from a publication by Paul Marik, and he's one of the biggest proponents of this therapy. I mean, he calls it the Marik protocol. But basically, the idea that if you combine hydrocortisone, vitamin C, and thiamine in patients with severe sepsis and septic shock, you can have a significant modulation of inflammation and great results. And this is a study that got published in Chest that really has a lot of methodological flaws, a lot of concerns, but it gained tremendous amount of press. And it's a before and after study with 47 patients in the before and 47 patients in the after study, and basically showed a tremendous difference in mortality in patients who received 1,500 milligrams of vitamin C every 4 hours, 100 milligrams of thiamine every 12 hours, and 50 milligrams of hydrocortisone every 6 hours for 4 to 7 days while they were in the ICU. And you can see on the right, the SOFA scores, which is a measurement of sequential organ failure assessment, which is a measurement of organ failure, how in the treatment group, which is those who got the vitamin C, thiamine, and hydrocortisone, there were significant decreases in the levels of SOFA score. This goes from 0 to 24, and you can see significant decreases by 72 hours that was not reproduced in the control group. So based on these almost like fantastic results, Paul Marik and his group have argued that it would be unethical to do a randomized trial in his institution because there's no equipoise, because they know that this saves lives. So they've been proponing the use of vitamin C, thiamine, and hydrocortisone for severe sepsis and septic shock. Next slide, please. And more recently, out of his institution, which is the Eastern Virginia Medical School, they really have pushed this MATH Plus protocol, which is intravenous methylprednisolone, high-dose intravenous ascorbic acid or vitamin C, thiamine, full-dose low molecular weight heparin, and then the pluses for zinc, vitamin D, famotidine, magnesium, and melatonin. So really, I mean, a cocktail of things, and this is the argument that they have in terms of how it should be initiated and how it works, and have really pushed this in social media, in the press, and a lot of people are utilizing and quoting this as evidence that we should be using vitamin C, with the argument of that it really has no harm or can produce little harm. Next slide, please. So this week, two very interesting studies. One large randomized multi-center trial, the ACTS trial, was released this week. This is 14 centers in the United States. They did have to evaluate a large number of patients in septic shock, but at the end, I mean, because of exclusions and a lot of rules, randomized 205 of these patients to either receive ascorbic acid, vitamin C, hydrocortisone, or thiamine, similar doses to what was used in the previous study, and the control group was a placebo-controlled group, so they received placebo in a very similar fashion, and their primary outcome was the change in the SOFA score at 72 hours, with secondary outcomes including kidney failure and 30-day mortality. So a large randomized study, multiple centers, placebo-controlled, and let's see what they found. The next slide, please. And here you have on the left the SOFA scores, and what you see is that over time there was a slight decrease in the SOFA scores, but they were very similar, and there was no difference between the placebo group and the intervention group. And the change in the SOFA score is actually very similar and numerically to the change in that before and after study that Marek proposed for the treatment group. So no difference when you do it in a placebo-controlled fashion. And when you look at the mortality in the Kaplan-Meier curve, there was no significant difference, but the mortality actually was a little bit higher in the intervention group, but it didn't reach any statistical significance. So I think for all means, it's really no different. So both the primary and secondary outcomes were negative. There was no difference between placebo and the intervention group. Next slide. A second study, smaller, but that actually focused on using vitamin C and thiamine in septic shock very early. So these patients actually were evaluated and initiated on this therapy in the ED. And this was a multi-center study done in academic centers in South Korea. And they were able to randomize a little bit over 100 patients, half of them allocated to receive placebo. So again, placebo-controlled with normal saline, and the other half received an infusion of vitamin C that was 50 milligrams per kilogram to a maximum of 3 grams, so that's 3,000 milligrams twice a day for 48 hours, and they got thiamine 200 milligrams twice a day IV as well. Now, of interest here is that in both groups, the treatment for septic shock included in many cases hydrocortisone. So the hydrocortisone was equally distributed among both groups, but the difference was placebo versus vitamin C and thiamine. And you can see the primary outcome was again the change in SOFA score at 72 hours, and the secondary outcomes included mortality at different time points, shock reversal, vasopressor-free days, duration of mechanical ventilation, ventilator-free days, renal failure, renal replacement therapy, and renal replacement therapy-free days. Next slide, please. And here, what's interesting is that they actually did measurements in all these patients of the vitamin C levels and the thiamine levels. And what you can see is that the vitamin C levels were similar at enrollment in both the treatment and the placebo. And as expected, they were normalized or significantly increased in those patients who got vitamin C at 72 hours. Similar things happened with the thiamine. There were similar at enrollment, and they were significantly increased in those patients who received thiamine. Now, what's interesting is that what they found was that at enrollment, around 50% or half of the patients are deficient on vitamin C, and that was completely reverted with the doses that they gave of vitamin C. So if, as people have alluded, it's the deficiency of vitamin C that we're trying to address. They addressed that when in the treatment group, yet there was no impact on outcomes. And the percent of patients who were thiamine deficient was lower in the range of 10%. And again, in the treatment group, 100% of those who were deficient were corrected with enough levels. So the supplementation of these vitamins does correct the deficiency, but it did not translate into any improvement in outcomes. So it seems that these two randomized studies are additional studies that include a series of other studies that do not support the widespread use of vitamin C and thiamine. I think that there's still people who keep pushing the narrative that there's nothing to lose, but study after study keeps showing that we're not able to reproduce those almost amazing findings of that before and after study. And I think that it's hard to recommend that we use this in a widespread way. I think there are side effects related to any drug we use in terms of distraction from other more important therapies, distraction in terms of research dollars, false hope for families. I think obviously when families hear that vitamin C can cure COVID-19 and their family members not getting it, they get upset. So I think that from a scientific standpoint, these two studies continue to add data that seems to suggest that there is no demonstrable difference between vitamin C, thiamine, and placebo in terms of organ dysfunction or mortality. Next slide, please. This is just showing the probability of death in this study, no difference in the Kaplan-Meier curve. And then the other thing that a lot of people have alluded to was the probability of shock reversal. So in the before and after study, the after study did not get, the before study group did not get hydrocortisone, so that was a difference. Here, both groups got the same amount of hydrocortisone, which we do know can accelerate shock reversal, and there was no difference here in shock reversal. So it doesn't seem that the vitamin C or the thiamine per se have really an impact on shock reversal. Next slide. So I think that before we move on, just to say that with remdesivir, we have another study that has a randomized study that has come out in moderate COVID. The results are not as positive as we would want, but we'll have to wait for other studies to truly understand what the role of remdesivir is. Continue to use it under the EUA we have. In terms of vitamin C and thiamine, does not seem that really there's data to support its widespread use. I think that because of how it's been popularized in the press and because some people keep pushing in social media, a lot of clinicians are still using it. But I really think that as we continue to accumulate data and randomized trials, that we really should start rethinking that and trying to stick with evidence-based medicine. So I'll give it back to Nate, who I think is going to share some clinician peer support information, and then we'll have some time for questions. Thanks, Nate.
Thanks, Sergio. So to reiterate, this is not a sound resource, but this physician support line is a resource that's provided by our psychiatric colleagues free of charge. I think their hours have actually extended substantially from when this screenshot was taken, and this will be informational and in the deck. Inside Sound, we offer employee assistance program, and we have our expanding physician support line. So I would encourage, anyone who's stressed that you've got a myriad of resources out there in addition to your RMD and the three of us. And here's a summary from the Wellbeing Portal, which Mark Rudolph and his team have worked hard to put together, which aggregates a lot of great resources. Take a look and check it out. And with that, I think we have some time left in the hour for questions. I'm not sure if we've gotten any via chat. I would encourage anyone who has one, type it in.
We do have a, oh, sorry, go ahead, Mark.
I apologize if you couldn't hear me. I just came off mute. Thanks, guys, for the awesome presentation. There's a really good question from one of our emergency medicine clinicians who notes that during the sound update, the COVID admission data was shared, but not the COVID-related visits seen in the ED. Working in the ED, I haven't had a shift in months where I'm not seeing patients with COVID or suspected COVID. Some get admitted and many don't, but there's a lot of COVID-related work being done in the emergency room. Would there be any value of tracking this to determine to what extent COVID ED volumes rise prior to COVID admissions, and maybe how many days the rise in admissions follows the rise in ED volume, sort of like an early warning system.
We would love
Nate,
to have that data. Yeah, this is Nate. So that's a fantastic question that we've put a fair amount of effort into. The problem is, you know, if you're admitted and you're an inpatient, you're going to have time to get a test result in places that have bottlenecks on turnaround time. And in the emergency department, if you discharge a patient and they're in the ED for, 130 minutes, in many cases, in many markets, you're not going to have that test back. So it's very, very difficult to get clean data on COVID-19, prevalence. We are working on the longer term to track, but we're not at a place with testing where we could utilize that for some type of early warning. But it's a great question, and it's something that we've thought a lot about. And I do think that, the saliva testing that we talked about a little bit earlier, or less complex tests that don't involve manipulation of the genome, but still are accurate and have test characteristics of PCR, may make more real-time tracking of ED prevalence possible.
Great, thank you, Nate.
And I think I'll just add to that, that the reason why we have the data that you see is because we capture it through our Sound Connect platform. Every admitted patient that either our hospitalists or intensivists see gives us the opportunity to ask some questions. We don't have that same ability with our ED practices right now, but to the person who asked the question, we all agree it would be fantastic information to have, and like Nate said, trying to figure out how to get there eventually.
Thank you, Sergio. Nate, here's another one that you may want to take a stab at first. What are the current nasopharyngeal swab test sensitivities, and how does repeating the test influence negative predictive value?
The real answer is nobody knows for sure. These tests, many of the ones that are out there are emergency use exemption tests, so there aren't, huge trials. The other complicating factor in terms of pinning down the exact test characteristics is that you don't have a disease, you don't have a gold standard, right? So without a gold standard test, it's challenging. All that being said, I think expert consensus would say that the sensitivity of the commonly available reverse transcriptase PCR testing is probably high 60s, low 70s, in that neighborhood. And it's also really important to remember how these test characteristics vary with prevalence. So there really is no one answer. If you're in a very low prevalence environment, you may run into issues with test characteristics that are totally different if you're in a very high prevalence. If you're in Arizona a few weeks ago when 20% of all COVID tests taken are positive, that's a much different environment from a test characteristic standpoint than, say, New York City, where, at the same time you were having positivity rates of about 1%. So not trying to dodge the question, but it's nuanced and difficult. And really the principal weakness of the RT-PCR tests is sensitivity. And, like I said, most people think that's high 60s, low 70s.
Sure. Okay, thank you. At this time, we don't have any additional questions.
And I guess, Mark, there was one more piece of that question that maybe I didn't completely answer, which was about negative predictive value. And, could you use the PCR test that's available today to rule out disease? And I think there are problems with that strategy. I think that using, the FDA, the CDC abandoned test-based return to work criteria for a whole bunch of reasons, but one of them was test characteristics of the available tests. And we've all seen reports of people that have had 3 or 4 tests from different vendors, then all of a sudden become positive. And there's a lot of nuance to it with where you are in the disease process, how much virus are you shedding, which particular PCR test are you using. I don't think that it's, if you have the disease phenotype and there's reasonable prevalence in the community, I'm not sure that there's adequate negative predictive value to rule out disease.
Sure. Thanks for adding that. Sergio and Greg, we don't have any other questions at this time. Any closing comments that you'd like to add?
No, I think that just to reiterate to all our clinicians how thankful we are for all the effort. For those of our colleagues who are in the Texas and Louisiana, we're now obviously also planning for Laura and for a storm and trying to figure out where that's headed and how that would impact some of our practices. But if you have any questions or things that you want us to cover, like we said multiple times before, please let us know, reach out to us via our sound email. And again, I mean, stay safe and thanks for all the hard work.
Yeah, I'm just reiterating what Sergio said. Again, for those who are in the Gulf Coast, we are keeping a close eye out there for you. Please let us know if there is any way that we can continue to support you individually or your programs. We encourage you to please send us emails regarding any additional materials, and please also look out for the emails from Nate, Sergio, and myself regarding the service line specific webinars that are also to provide you additional information.
Nate, anything else?
Just reiterate thank you to everyone, and remember that this is by us for you. So if there's anything we can bring you from a informational standpoint that would help, let us know. And thanks for attending.
Well, thanks very much, everybody, for tuning in. And I'll just reiterate one thing that Nate brought up with regard to peer support and those other resources for mental health. Even if you feel like you don't need something like that, maybe you've got a colleague who does. And so suggesting these resources to them may prove valuable to somebody else on your team. So thanks for the great work you all are doing and for tuning in, and we'll talk to you in a couple of weeks.